دكتور عمرو الكرمي، دكتور قيس البلبيسي، دكتور نزار، دكتور لبابة، دكتور رائد العوايشة. قيس.
يعطيكم العافية جميعاً. Our next speaker does not need introduction. He's a very well-known super interventional cardiologist in Jordan, Dr. Raed Awaisheh, who's going to talk about a subject that I think he's extremely familiar and knowledgeable in. So, Dr. Raed, we're looking forward for your lecture. Please, CTO Strategies and Updates.
Shukran, Qais. Thank you very much for everyone. Maybe everybody went out for break, Dr. Mahmoud. Anyhow, we continue, and because we are really out of time. What am I going to elaborate in the coming 15 minutes? Actually, what we have in CTO till now, I hope that I elaborated very well, and I would like always to start when I talk about CTO to talk about the myths that we have about CTO. The first myth that CTO is a rare finding. Is it a rare finding, really? And after that, would it cause ischemia in the presence of collaterals or not? Medical therapy is enough. And CTO do not affect mortality, and CTO have poor success rate. All of these myths, actually, now they are a myth. So what are we going to do? CTO is a rare finding? No, actually, we have it in 15 to 20% in most of the studies, an average of 18%. Most of these patients, when you have a severe ischemic heart disease and CTO, most of them, they go for medical therapy. 44% they go for medical therapy, and 26% they go for bypass, but 30% they go for intervention. And for those who go for intervention, 10% attempting CTO, they leave the CTO attempt only 10%, and the success rate is only 7%. So really CTO is really a challenge and difficulty, but it is there, it is there. It is 20% of the cases of ischemic heart disease. When we come to CTO is rarely causing ischemia because you have good collaterals. The best collaterals actually shown in many studies that they are not enough actually to support the area where you have a CTO. It is not enough. So all the collaterals, whatever collateral you see, and this is actually what I have seen in the patients and everywhere, that, okay, your vessel is filling from the other side, so this is enough. Actually, it is not enough at all. And this is proved by this FFR study. By FFR study, no collateral is enough actually to support the area. And this leads us to, okay, so patients with CTO, shall we do every patient with CTO? Till now, also supported by the guidelines, and this is what I will elaborate, that we need to go for PCI for CTO patients when we have symptoms. But very important about symptoms, what is the point? It is not just angina. We are not talking about angina. We're talking about angina, heart failure, dyspnea, arrhythmia. All of these are symptoms that when you open the CTO, you improve the outcome. So this is very, very important, especially when you have patients 40s and 50s. It is not really actually to see CTO in those patients. And in this situation, you put the patient on many medications, and you know the effect of these medications on the patients, especially in male patients, all of them. So the best thing actually, to avoid the medications and to open that vessel. Okay, how about when you have impaired LV function? When you have the impaired LV function and you know that this impairment is due to that CTO, so after opening with that area, improve or not, you have the imaging studies, and we can do that and we can elaborate it. So this is the important point. Maybe what's against CTO is in the studies, there is no improve in the survival. This is actually what makes opening the CTO is not that encouraging for everyone to open CTO, because that did not reflect in the randomized controlled trial for improving survival. But imagine if you have a patient with single vessel, and the other vessel is CTO. So if this patient develop MI in that vessel, this is what we call it jeopardy theory. So if you develop MI in that single vessel, of course, the result will be disaster. If you have two vessels, that will be better. So, okay, so I will do them. I will do the CTO. So we will go for patient selection. Which patients you will do? Patient with symptoms with angina that will get benefit? Yes, I will do. Okay, what else? What is the chance of success of doing this CTO? This is very important actually to evaluate and assess that how much you will be able to open that. Do you need equipments? Yes, you need different equipments. Do you need interventional experience? No, you need more than interventional experience. It's not enough actually to be an interventionist to be able to do CTO. Yes, start with CTO as interventionist, CTO the simple cases, but difficult cases sometimes you need to go more, and this is actually what will come soon. Now, for a patient, you will do revascularization. If a patient had MI, you go for viability study to be sure that that area will get benefit. If the patient did not have MI before, you go for ischemia study and look for ischemia, functional ischemia. And if the patient has multiple vessel disease, of course you go for CABG. But if you will go for PCI, start with CTO first. If you succeed with CTO, you continue. If you did not succeed with CTO, you refer back the patient to CABG. This is very important because what I see that all the simple vessels are opened and the CTO left behind with a significant ischemia behind it. So there is no full revascularization. So full revascularization is very important. Still, the guidelines, the European or American, gives it 2A, 2B. Why? Because it does not reflect on survival. This is actually, presence of CTO will affect the way how we treat, isn't it? You go with taking the patient more for CABG, you send patients more for medical treatment when you have CTO, while you don't have CTO, you go for PCI more. Okay. The success rate is very important actually in this study. If you have, you need experience, you need tools, you need to know about the tools and to build the experience first. So this will enable the success. It's very important actually because this is key point lecture. So I will just give point about the wires. We have more than 300 wire now for CTO. It is not necessary actually to have all of them in your cath lab. But it's very important actually to differentiate between the wires in two things according to the tip stiffness. According to the stiffness of the tip, you divide them into two wires. Wire for negotiation and wire for penetration. So just have 2 or 3 wires for penetration, 2 or 3 wires for negotiation in your cath lab, and this is enough. Very important point actually when you decide to do CTO to have dual injection. Dual injection right and left. Most of the now cases right radial, distal left radial. This is the routine nowadays. But no shame actually of going for femoral because sometimes you need for femoral 7 French or 8 French guide catheter to have a good success rate for your CTO. So if you need femoral, go with femoral. Okay, dual injection technique. You go with dual injection. You go and put the protection wire in the donor vessel. Don't forget that, please. Wire in the donor vessel because if anything happens in the donor vessel, you have the wire there, so you can save it. If you have a thrombosis, dissection, whatever, you can go and fix it up. So you need the wire prior to starting doing the CTO. Now, CTO, as you know, the procedures that we do either antegrade, retrograde, or hybrid. For antegrade, we go either with wire escalation or ADR, antegrade dissection re-entry. For retrograde, also wire escalation and RDR, retrograde dissection re-entry, and the hybrid. Which one to decide? How to decide? We decide according to the ambiguity of the cap, the proximal. You look for the distality. You can see it very well. You measure the CTO, how far they are. This is very important actually to decide to go for proximal, to go for either antegrade or retrograde. So the JT score helps you in doing that, and to have and then after that you assess the collaterals. Do you have good collaterals there? You can go from them or not. So this is the way to go, and this is when we have these approaches in comparison the year 2000 and the 2020s. Now, we have the differences that more success, we have more wires. Now, with the technique success, we increase we improve it from 70 to 90%. Let me make it more interesting and to go with the cases and to show you when to go with antigrade, when to go with retrograde, when to go with hybrid. For example, this is a case. You can see that there is CTO in the, or as we call it, functional CTO in the LED. You have a CTO in the circ. For this patient who had cabbage, in this case, you go for antigrade. You can see that it's well-defined, tapered, proximal cap, well-defined, distality. It is not that long. So you go with the wire and go with the negotiation first. Always choose wire for negotiation first, because most of the time you can see micro channels. And the micro channels, you can go with wire. So if you don't have micro channels, you have difficulties, you can escalate your wires. You go escalation, 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 according to the stiffness of the tip, as I said before. So here, this is the antigrade. You succeed. This is easy. Or at the beginning, you start with doing these cases. Then you go, for example, on the same thing. This is the LED. The same thing. The proximal is clear. The distality is clear. You can go with the wire. Here we may need ADR, but by the end of the day, this is the antigrade approach, and this is finished. Okay? How about if you have ambiguity or no? This is another case. This is an example for ADR when you go for ADR. This is a case you have CTO in the LED, you have a CTO in the circ, and also you have CTO in the RCA, and the patient is in angina class 4. So you need to do something, and definitely you go for the LED. That example I showed you how you go with wire escalation. In this case, I show you how you go with ADR, antigrade dissection reentry. Antigrade dissection reentry, you go with the wire, you go with the balloon. Here we crossed, but the balloon doesn't follow, and this is what you should know. Doesn't follow why? You can see this very well that the guide is in the aorta, swimming in the aorta. So you need to improve your anchor. So you need to learn about the anchor techniques and how to do the anchor techniques. Sometimes wire anchoring is not enough, isn't it? It's not enough sometimes. It's not really giving me the good support. So what to do? I go with balloon and inflate it in the other vessel, especially that I have a stent. If I don't have a stent, in this case, I have a lesion in that vessel, so I fix it. And before fixing it, put the wire behind the stent and distend the wire. So this will give you a hard and stiff fixation for your guide in the left main, that you stent the wire behind the stent, and this is good fixation, and you continue the case. Here in this case, you go with granuloplasty, all the techniques for antigrade dissection re-entry. Maybe they failed. Here we pulled back the wire to go with rotowire that failed. So we go with hydraulic dissection, star technique, and then you go for knuckle. It is very important actually to choose the right wire for knuckle. You go for small knuckle or for big knuckle. Okay, these are technical points that knuckle is not good. This is the good knuckle. And after you go with knuckle, if you go with ADR, you should measure it before, and you know that how you will go back to the true lumen. So what we call it re-entry. So you should calculate, and you know very well, and you have the tool inside your cath lab, either Stingray if you have it, and we don't have it actually in Jordan, or double lumen microcatheter that we have it, or triple lumen microcatheter. When you have this, you can go and re-enter, as in this case. You know the AFR, the CTO operators, they know all of these techniques, how to do the AFR, the ADR, star, the mini star, and all of these things. Anyhow, in this case, okay, succeeded, re-entry, and taking the two different stiffness of the wires. The Japanese actually, they go with injection in the distality. The Europeans, they don't like it. And the way to do it, that you be sure that you are in the true lumen. You go with the soft wire if you will go with the practice, according to the European. For the Japanese, you go with the injection. And this is the end of this case. This is an example for CTO with ADR, antigrade approach. Okay, how if you have ambiguity in the ostium? Like in this case, you can see that the RCA filling the left system. And look at this left system, you can see the circ, but you see the diag, or something is going there, but no LED, no LED, no LED, no DAGs even. So what to do? No good collaterals from the RCA. So you can go with ipsilateral retrograde from the circ to the LED, and you open the LED. How you open the LED? You open the LED by doing the ping pong technique and all of these things. I will not explain too much about the wires, but you need to select the wires, the right wires for septal collaterals, for epicardial collaterals, and for all of these techniques. And you finish the case by doing whatever. So finishing the case by stenting, and this is the final result. This is when you have ambiguous. So when you have ambiguity in the proximal cap, definitely retrograde approach is the choice, is not antegrade. You may go with antegrade approach in ambiguity in the proximal cap. IVUS guided penetration. I'll have an example, but I will not show it for the sake of the time. I think I'm running of the time here. But this is the hybrid approach. I will just give, I will excuse you for one.
Actually, you have whole time. The two lectures after you have apologized.
Oh, really?
So you have time.
So
But I mean,
not that much.
still want to go to lunch.
Take 1 minute, but not more. Okay. So in the hybrid approach, this is how you decide. As I told you, very clear proximal cap, tapered or not tapered, blunt, tapered. You need to know. The distality, you see it very well. So, and the length in between, this is how you decide. According to the GT score, we decide. Sometimes, and this is very important to take it in your consideration, that the tortuosity of the vessel. It is not always that I have this point, and I have the CTO between them. It is not always straight, isn't it? This is what we do usually. So maybe it is tortuous. You expect that it is going this way, but actually maybe it's going this way. So how do you know? This is the beauty actually of doing the CT before. So CT before, it will give you an idea about the course of the vessel, so you will decide how you go, especially when you go for hybrid approach. For example, in this case, you can see that the RCA here, you have good collaterals actually from the lift system to the RCA, the distality. The distality of the RCA, as you can see, there is RCA there, but it is not clear, the distal part of it. Maybe BLB, BDA, you can see them very well, but you don't see well the distal segment of the RCA. And when you go for the proximal or the, when you go for, sorry. When you go for the RCA, look at the RCA. You have a side branch. Your wire will keep going to the side branch. We know how to go overcome this problem, but this is very, very, very long segment actually to overcome it, isn't it? So how to do it? Okay, I will try to, of course, to go with the retrograde and antegrade as a hybrid approach. I'll first to select the collaterals. Which collaterals to select? Here we have septal collaterals, we have epicardial collaterals. Always start with septal collaterals. Always start with septal collaterals because it is safer. Epicardial collaterals, this is after you have a good experience, you have the good tools, then you go for the epicardial collaterals. So here in this case, actually, I did not, even they are working very well, 3-4 septal collaterals, but they are not connecting. Okay? So here in this case, I was pushed to use which I hate, actually, is to use the epicardial collateral. Epicardial collateral, the first thing to prepare is to have the pericardial synthesis set beside you before you do it, because epicardial collateral is very fragile. You may have tamponade, and especially in a patient who had CABG in the past, any leak in the pericardium, the patient may crash down. Also, you need to take care about the dry tamponade, which I will not talk about now. Anyhow, so here, I succeeded actually, as you see, that the wire crossed to the RCA from the epicardial collateral from the left circ. We continue, actually it goes up there, but also you need antegrade now. Now I can go and come encouraged to go with antegrade. The calcium can lead me actually to go in the right course. Here, I tried reverse card did not succeed. And again, another one, I have tried here to go with you can see the tips of the two microcatheters, here one microcatheter and here another microcatheter, and try to have the connection between them and to have the microcase, what we call it microcase, or inside the catheter, we call it the rendezvous, technique. All of these techniques actually are technical. With time you build up your experience and all of these techniques and which one to choose. And when you always need to have an alternative plan. If one did not succeed, you go with the other one. If one did not succeed, you go. So in this case, actually, you succeeded with ADR and RDR. Both of them to achieve this is ADR and RDR together, and then I achieved externalization for the wire by having the external extension guide catheter inside the vessel, and the externalization you can go with the external guide catheter is one of the techniques that you go for externalization. So you need to go for externalization, either for extension guide catheter or to snare the wire, or with the microcase, or what we call it the rendezvous technique inside the catheter. So this is the end of this result. Nowadays, this case actually I have done last week with CTO for the 3 vessels. CTO for the LAD, CTO for the OM, the third OM, and CTO for the RCA, the distal segment. And this is, as you see, in this case, you have the OM here, CTO, and the LAD CTO. In this case, all of the 3 CTOs actually treated by DCB, no stents, with different techniques of the CTO. For this LAD, for example, I did ADR. For this RCA, I did it, the BDA, we did it by retrograde approach, and the crux and the kissing technique, all of them done by doing it by DCB. Here the ADR, and you can see that always after ADR, definitely you will see some dissections. This is the circ, this is wire escalation, and both of them are treated with 2 DCBs in the LED, 2 DCBs in the circ. And also the RCA was done in the same way, retrograde, and also DCB at the crux. So I will conclude in this case. Now, DCB actually is very good to avoid the metal jacket. Huh? Okay, so I will conclude now. I think, thank you for giving me extra time. The first important point is that CTO is not infrequent. It's not infrequent. CTO is there. It causes ischemia. Sometimes it is necessary actually to open it. Sometimes it's valid to open it. Medical treatment, sometimes it is not enough. Still in the guidelines, it is not that strong because of many things. The most important thing is the reflecting survival, and the second thing, the chance of success. You can increase this chance of success by giving it more consideration, especially in symptomatic patient. And I think now the stentless PCI CTO is the way to go with using the DCBs. Thank you very much.
Thank you, Dr. Thank you, Dr. Raed, for such a great presentation. A couple of questions. First of all, of course, as you said, when you anchored that wire and you jailed it to achieve some support, you could sometimes just, without having necessarily a stent, maybe you had a lesion, that's why you did it. You could just put a balloon and it can anchor that way. Of course, you need to make sure that wire is not a hydrophilic covered wire, because when you're removing it, if it's a hydrophilic, you're stripping it and you're leaving the material behind. The other point, coming to the DCBs for CTOs, does it work for all types of CTOs or approaches? You're having dissections there, or just the anti-grade wire escalation method?
Great questions. Really great questions. Actually, for the anchor technique and for the wire, I agree 100% with you that you choose your wire, that it doesn't leave something behind when you pull it back from the stent, and not to slough, especially the outer coil. The outer coil these days, actually, even for the hydraulic, they are well manufactured that it will not slough. I have seen it many times. We stent, we keep the wire. It's not wearing as before, because now really the wires are good. But yes, it's well taken. Not at least the hydrophilic type, maybe with just the core. But these are stiff wires, so you need all the hydrophilic wires. The second question about the DCB, yes, I agree. Till now, we have the wire escalation. The the CTO that you open by the wire escalation is the best outcome to have it. The best outcome actually to have it when you don't have dissection, remnant dissection. But this is also reflect on the same thing as acute MI when you have dissections. And part of the success of the DCB actually is to have dissection. Sometimes we do dissections actually to elaborate, to allow the drug to elute in the subintimal space and to build and utilize the vessel again. So sometimes dissection are not a problem. What I prefer always, not only in CTO, everywhere we do DCB, is to go with IVUS. To go with IVUS and to assess that dissection. Definitely, if you have any effect on the TIMI flow, that this is not acceptable. You need to go for a stent. Whenever you have when you have significant dissection more than 180 degrees by IVUS, yes, I go for a stent. It is not enough actually, or not good to go for DCP.
I'm not sure, probably that would be on your side, but we always blame ourselves as cardiologists, and we're always looking for mortality benefits.
Yes.
And that's unfortunately not with the surgeons, but we always get the blame. For example, if you look at the historical data of CABG, show me any prognostic benefit with the exception of left main in a depressed LV. They don't have a big impact on mortality. While everybody looks at us while doing CTOs as CTOs operator, what's the mortality benefit? Ignoring that this patient is actually symptomatic, had a really not the best quality of life. Second thing, which I don't think you pointed it out, but I think I have to point it out. If you're attempting the CTO, you have to finish that CTO, either in that session or the second session, because the mortality actually of a failed CTO is much higher than leaving him on medical therapy.
Exactly.
Yeah.
Exactly. Two very, very, very good points. The first point, I'll start with the when to do CABG, in CABG to CTO. CABG is better when you have good lima to good LAD. If you don't have a good lima to good LAD, in all the studies, we don't have that difference between PCI and CABG, because you have a spontaneous, you have immediate, during hospitalization after CABG, you have a spontaneous SVG closure. So CABG still till now beats the PCI even for CTO or whatever, when you have a good lima to good LAD. This is the first question. The second question, definitely very important point. Dr. Amr, thank you very much for telling me it. Always plan yourself. Time, contrast, and amount of exposure to radiation. When you reach this limit, you need to know your limit. It is very easy. It is easier actually to know when to start, but maybe it is harder to know when to stop. So you need to fix for your time when to stop. And sometimes, and I did not show it, but I have cases where you stop and bring the patient after 3 months because we have intravascular, what you call it, intravascular hematoma. You go subintimal, you cause hematoma, everything gets blurred, you see nothing, so you stop there if you will not do the aspiration and sucking, and many techniques, other technique. Stop there, after 3 months, come back, you will see it easier and you will go easy and open that vessel. Yes. Dr. Raed, sorry.
Sorry, Ms. Moore. I guess the myth that the CTO community cannot answer, you claim that when you open a CTO, you improve LV function, right? So if you improve LV function, how come you don't get mortality data when the medicine that improves LV function get you that mortality benefit? So I guess there are some questions and answers in the CTO community that I think more and more studies will be able to answer that. My second comment about the DCP, yes, if you have a dissection class 3-4, you cannot use the drug-coated balloon. It has no benefit because the vessel will close eventually. Thank you.
Yes, regarding the LV function, very important. Yes, we did not see it in every CTO. That's why CTO is not encouraging doing any CTO. Till now, which proved really is the symptoms, and we talk about symptoms. It is not just angina, heart failure, arrhythmia, These are symptoms. You consider it as symptoms. How we confirm or know before doing CTO that this CTO will improve the LV function? As I told you, if you have a patient with prior MI, he had MI, previous MI, you go for viability for that area of the CTO. If it is viable, yes, he will gain benefit. If it is not viable, he will not gain benefit. And for patients who do not have MI in the past and you have ischemia here and there, you go for functional ischemia. And we have a limit for it, 10%. If you have ischemia more than 10% of the myocardium for that CTO area, after you open it, you get the improvement in the LV function.
Your scenario is completely incorrect. If you have a 70% lesion in the proximal LAD and you approach it without evidence of a kind of ischemia, I think you are not doing a patient a favor. This is completely commercial PCI.
No, we're still doing it because we think we're doing it.
No,
doing
we
it
need to do
So-
it. We
so-
need to prove ischemia.
Yes.
Because for the same token, CTO, if you don't have ischemia, if you
Yes.
don't have good symptoms related to that CTO,
I will take
think
you.
you shouldn't.
I will take you to another one. So if you
I-
got
that-
70% proximal LAD in a normal LV function, you're still doing it.
No,
In symptomatic-
absolutely, I will
Without
not.
symptoms.
Top. Okay, so if
Let
you
me-
got a CTO in a normal LV function in a symptomatic patient,
Yes.
why
So-
are you still saying
May
I want an evidence of
may I
ischemia?
interfere here?
Again-
So basically, yeah, if whenever we're fixing stable disease, it's mainly for symptoms. Now, I know there are some high-grade lesions like proximal LAD or left main that you're worried there's a big area of ischemia, but you still have to prove ischemia
Yes,
before you
absolutely.
fix.
This is
So
actually
I-
by the studies, Qais. By the
now,
studies, actually, when you
by
have 10% even less than 10% ischemia is not enough.
That's indicated.
It's
But
not
You
enough.
should prove that there is significant ischemia to fix it in an asymptomatic, stable disease patient
Yes.
in order to fix it. Now, the counter argument, I know your counter argument. The counter argument is that a lot of those studies did not include high-risk patients, high-risk ischemia patients, so you really don't know whether you fix them without symptoms or without proving is going to help or not. But the recent trials, especially like ischemia trial, showed no, that you should prove ischemia and you should treat better.
Yeah,
But
if
I
you
argue-
look at the ischemia,
Amr, I
I'll
will
take you
answer
back
instead
into
of you.
that
Amr,
because
Amr.
my center was involved in that ischemia trial. Sorry. If you look at the crossover between medical back to intervention in those patients in 6 months' time, you may change your mind.
But still, the overall statistically significant data showed that
Nobody
you
talking
allow me,
about the
please?
crossover.
Yes,
Can you
Raed.
allow me?
Raed.
This is an educational conference, and I think the take-home messages for our junior fellows and colleagues is that ischemia is a must. If you are going to move to the oculostenotic reflex of every artery that needs to be closed more than 70% to be opened, I think we are giving the wrong message. So we need to stress on that. Now, your expertise with time might let you say that this 70% is very important to this patient, that's allowed. But for the general interventionist, ischemia should be there.
agree. And again, symptoms, as you said, is an important reason. Now, let me ask you this question. How many knee replacement surgeries are done in the world? Knee surgery is not going to improve your survival, but we still do it. Why? Symptom
Improving the
relief.
quality of life.
So symptom relief and improving quality of life is a very important
Yes.
and very good reason to do a procedure.
Yes.
You know, it doesn't make it less of a reason to do something.
Exactly. This is what I mentioned actually about male patients, lots of medications on CTO. What's the gain?
Okay, thank you very much. I would like to ask a question about drug-eluted balloons and the CTO. You as an advocate, do you think it is like safe, because we don't have enough data, to go for drug-eluted balloons only, or you prefer more like a hybrid strategy? You put a shorter stent in the true CTO segment because you have a lot of dissection re-entry, and then you continue and you finish with drug-eluted balloons, like to shortening the size and the extent of the stent. Do you, as of your experience, because we don't have real data right now? Thank you.
I agree 100% that we need data, we need the randomized control trial studies to know exact answer for this great question. But what we do at meantime, I treat CTO after I open it, same as any vessel by IVUS guided DCB or stent or hybrid. And this is, we do it according to the basic things simply. If you have a dissection more than 180 degree, if you have a dissection impair the flow, if you have a residual stenosis of more than 30%, if you have a significant recoil, if I have a significant hematoma that always keep filling for that segment, I go and do hybrid stenting or stenting instead of DCB. If I don't have any of these things, I treat CTO same as any other lesion.
So Raed, in real life, how many patients you do IVUS on them after you open the CTO?
50% in for my own. For my own, what I do actually is 50% or sometimes even less than 50% because you know it is very costly procedure and you increase the cost. But as I told you, I never regret actually using IVUS. IVUS is amazing actually. You see the angiographic result is excellent, but when you do IVUS, oh my God, what I'm doing there. I still have significant calcium there, significant stenosis there. No, my stent did not open very well. Did not open. In one segment, I don't, last case or 2 weeks case, after I did IVUS, I needed 4.5 NC balloon actually to open a vessel that I bought. I was by angio, 3O stent was enough.
Do you use stent boost regularly?
A stent boost, it's excellent, but stent boost will show you the stent.
But like
The life stent boost also will not give you the real. It will give you the structure, but it is not enough. But it is good. It is good. Many times actually.
I'm not comparing stent boost to IVUS, but
Yeah.
I'm saying that it's something which is there.
Definitely.
And it's not expensive, and sometimes it gives you an idea of
we
your,
we use it a lot.
expansion.
We use it a lot. Actually, use it. Yeah, but it is not costly at all, and sometimes it really gives you a very good idea, especially when you have any binge or any not too barrel lines of the stents. You know that there is something there, and you do it. Not only that, yes, stent boost also for the before putting it to see the calcium. It helps you actually to show or make blurring on the calcium of the vessel by doing stent boost. Also what's one of the advantages.
All right. So thank you so much. Thank you, Dr. Raed. Lunch time is now. Thank you, everyone, and we'll see you, Dr. Mahmoud, when? And at 2 o'clock? We're done, but when should we meet again? After lunch.
After lunch, we return back here at what time? At 2 o'clock we return back.
2
Thank you
o'clock.
very much for everyone. Thank
2
you.
o'clock. Thank you so much.